Okay. So, good morning, friends. Welcome back to Saturday Club of Baroda morning meeting. And today we have a very young pediatric neurologist with us. He's Dr. Sridhar Joshi. He's an alum of Baroda Medical College only, but later on he had the pediatrics at Lady Harding Medical College, New Delhi. And he did his DM pediatric neuro at a very reputed institute, Christian Medical College, Vellore. His areas of interest are neurodevelopmental disorders, complex epilepsy and pre-surgical evaluation for epilepsy surgery, radiogenomics in neurometabolic and neurogenetic disorders, pediatric stroke, movement disorders, and chronic long-term neurorehabilitation. To his credit, he has several presentations and publications. And post-DM, he had worked as assistant professor at CMC Vellore for a couple of years. And now he's starting his practice in Baroda. So as the Saturday Club tradition goes, we try to encourage young consultants who have qualified recently and starting new practice. So we come to know about their experiences and their knowledge repertoire. So welcome Dr. Sridhar Joshi to Saturday Club of Baroda. And now he'll be talking about drug-resistant epilepsy, clinical approach and beyond. So over to you, Dr. Sridhar. You have about 40-45 minutes to talk and we'll keep 10 minutes for interaction. So over to you. Thank you.
Thank you, sir, for the invitation. I'll share my screen, sir.
Yes.
Is my screen visible, sir?
Yes, just put it on the slide, sir.
Sure.
Yes, well visible.
Okay, sir. Good morning, teachers and mentors. So I'll be starting my talk on drug-resistant epilepsy, clinical approach and beyond. So we'll be going through definition of epilepsy and various other definitions related to it, the framework of epilepsy classification, clinical approach based on cases which we managed in our epilepsy surgery unit, and management and its advances. So in 2005, Robert Fisher and group from ILAE proposed the conceptual definition of epilepsy, which they defined as disorder of brain characterized by an enduring predisposition to generate epileptic seizures and by neurobiologic, cognitive, psychological, and social consequences of epilepsy on the individual. And they defined epilepsy requires occurrence of at least one epileptic seizure. But this was a conceptual definition. And how do we define neurobiology, cognitive, psychosocial, and consequences was not defined that much. So in 2014, ILA came up with a practical clinical definition of epilepsy, in which they defined epilepsy as a disease of brain, in which we require any one of the three, which is there. We need at least two unprovoked seizures occurring greater than 24 hours apart, or reflex seizures. Reflex seizure means a normal stimulation like light, sound, food, writing, all those things don't provoke seizure. But if normal stimuli like light, sound, food provoke seizure, they are known as reflex seizures. So we need at least two unprovoked seizures or reflex seizures occurring greater than 24 hours apart, or one unprovoked seizure, and the probability of further seizure, which is similar to general recurrence risk after two unprovoked seizures. That means if a child has one unprovoked seizure, but has a neurodevelopmental delay, has abnormal brain MRI, has abnormal neurological examination, then the chance of second unprovoked seizure in that child who has these predisposing factors is almost similar to a child who is not having any neurodevelopmental risk factors up to 60%. So even with one unprovoked seizure, we can define it as epilepsy and start anti-seizure medications. Or we have a diagnosis of epilepsy syndrome like West syndrome, Lennox-Gastaut syndrome, Landau-Kleffner syndrome, etc. So this is the basic practical clinical definition of epilepsy. And of these three, if anyone is fulfilled, we define the child or patient to be having epilepsy. And they also went one step further and defined when do we call epilepsy as resolved. So if a child has age-dependent epilepsy syndrome and they are now past the applicable age, that means let's say a child has benign Rolandic epilepsy that usually occurs between 5 to 12 years. And if the child is now 14 years of age, he is past that applicable age and he does not have any seizures after starting after 2 years of anti-seizure medications, we call that epilepsy to be resolved. Or if the patient has remained seizure free for 10 years in which he has been having no anti-seizure medications for at least last 5 years. So this is the definition of resolved epilepsy. So this is way more practical for clinical aspect, and this is how we usually treat our patients. Then the group by Patrick Wan and Jacqueline French gave a definition on drug-resistant epilepsy, where they defined drug resistance as failure of adequate trials of two tolerated and appropriately chosen and used anti-seizure medication schedules, whether as monotherapies or in combination, to attain sustained seizure freedom. So each and every word is important over here. When we say appropriate, it should be appropriate for patient's seizure type and epilepsy syndrome. For example, in myoclonic epilepsy, sodium channel blockers like phenytoin, carbamazepine, and oxcarbazepine are relatively contraindicated. So if a child has juvenile myoclonic epilepsy and if the child is on combination of two sodium channel blockers, he will never achieve seizure freedom. So it's not appropriately chosen. Even if he's on 3 drugs and if he does not have seizure freedom, we cannot define that as drug resistance. Second is adequate trial. That means the drugs are used in maximum efficacious doses and for sufficient amount of time. That sufficient amount of time is defined as at least 6 months to 1 year. And the child has sustained seizure freedom. That means the child is seizure free for at least 1 year after initiation of drug schedule or more than 3 times the largest seizure free interval documented. So suppose the child was on valproate combination, valproate and clobazam, and he was seizure free for 3 months. Now, if the child is seizure free for 9 months on that combination, that is more than 3 times the largest seizure free period documented, then we call it sustained seizure freedom. So if the child on this 2 drug combination like valproate and clobazam does not remain seizure free, which are adequately trialed and appropriately chosen, then we define the child to be having drug resistant epilepsy, and then we have to further work up based on that. So this is the basic framework of epilepsy classification. So this is the ILAE classification. So initially we have to define seizure types, whether they are focal onset, generalized onset, or unknown onset. That requires someone to see the child seizing live. So if they have seen and they have seen the onset, then only we can define. If it is not seen, if some parent enter the room and the child is seen seizing, then it is defined as unknown onset. Based on the type of onset of seizure, we defined epilepsy to be a focal epilepsy, generalized epilepsy, combined focal and generalized epilepsy in which both focal onset and generalized seizures occur, or unknown onset epilepsy. And based on that, we define epilepsy syndrome. Apart from that framework, we also have to define the etiology of epilepsy. This is the most important thing. What is the etiology of epilepsy? Whether it's a structural, genetic, infectious, metabolic, immune, or unknown etiology. And we have to also define comorbidities like behavior, learning needs, cognitive decline. All those comorbidities also need to be defined. So this is a holistic framework of working with epilepsy. We need to define the epilepsy syndrome, the etiology of epilepsy, and the comorbidities. And each and every part is essential for targeting and appropriate management for the child. So how do we approach drug-resistant epilepsy? This is what my mentor taught me. This is not from an article. So first we have to define whether it is epilepsy or epilepsy mimic. I don't have time to go through all epilepsy mimics in this talk, but if usually lots of patients with syncope or children with shuddering attacks are considered to have epilepsy and they are started on anti-seizure medications. and then it continues despite anti-seizure medications, and they are referred for drug-resistant epilepsy evaluation. But usually, it's usually epilepsy mimic. So a good history is very important to determine whether it's epilepsy or epilepsy mimic. Second most important thing is a good video of the child. That video is the single most important step which parents bring to us, which helps us define whether it is actually a seizure or a seizure mimic. If it is epilepsy, we have to know whether it's a structural, lesional, or focal epilepsy. That will be known by the investigations, which we'll discuss. And is there a pseudo resistance? As already discussed previously, is the drug combination given appropriately, adequately, or not? Because if the drug combination is not perfect for the type of epilepsy, the patient would go on seizing despite multiple number of drugs. So the usual dictum goes that we should use drugs with different mechanism of actions, and their pharmacokinetics should not overlap with each other. And it should be appropriate for the seizure type. So for example, in myoclonic seizures, sodium channel blockers should not be given. And broad spectrum AEDs like valproate can be initiated. If it's epilepsy and if there is a drug resistance, then we have to see that whether there is a concordance between three investigations: the history, that is seizure semiology, EEG, MRI, and or if there is concordance between, if there is discordance between two of this, then we have to do nuclear medicine scans. But in this day and age, it's not required that much. I'll show further. If there is concordance on two or more of this above, we proceed with pre-surgical workup. And in pre-surgical workup, we have multidisciplinary meet with a neuropsychologist, developmental pediatrics, neurosurgery, and pediatric epilepsy surgery unit. And then we proceed for epilepsy surgery. However, if the epilepsy is because of non-lesional lesions, genetic, or malformation phenotypes, then we have to go for pharmaceutical and non-pharmaceutical therapies. So let's see case by case, and that will make our understanding more clear. So this is a 10-year-old male child. He had a significant perinatal history characterized by oligohydramnios and birth asphyxia. He started having habitual daily seizures since 7 years of age. The seizures were characterized by right focal motor seizures with impaired awareness. He also had atonic drops and also generalized tonic-clonic seizures. Comorbidity-wise, he had global delay, behavioral and learning needs. He was tried on 4 appropriate anti-seizure medications. However, there was no response, and there was deteriorating behavioral and scholastics. On examination, he was left-handed and had subtle right hemiparesis with pyramidal signs. The imaging shows left parieto-occipital gliosis, we can see, with extraocular dilatation of the lateral ventricle. And we can also see the EEG. So for EEG, I'll just say the odd numbers are from the left side and the even numbers are from the right side. The first two are the parasagittal leads and the second two are the temporal leads, and this is a central lead. So here we can see that the EEG shows discharges from the left side, the odd numbers. And the lesion also is on left side and the seizure is on right side. So here we have clinical concordance, electrophysiologic concordance, and radiologic concordance. So we have concordance in all the three. And the child has failed 4 anti-seizure medications, which are appropriate and adequately tried. So this child fulfills the definition of drug-resistant epilepsy. He has clinico-radiological, electrophysiological concordance, and his seizures are drug refractory, and he's also having deteriorating comorbidities. So this is a candidate for epilepsy surgery, and we proceeded with a right posterior quadrantectomy, and then now the child is seizure-free. It was done in 2015. The child is seizure-free and now currently is employed under supervision. So the benefits of epilepsy surgery just go beyond seizure freedom. We also target the comorbidities, improve the comorbidities, and give those adolescents and adults a good quality of life. But before epilepsy surgery, we have to plan meticulously whether they are actually a candidate for epilepsy surgery or not. Coming to second case, this is a 20-year-old female who presented to us at 12 years of age. She had weekly seizures, which were characterized by aura of fear, had epigastric rising sensation, right upper limb automatisms, and left upper limb dystonia since 7 years of age. She has been treated with 3 anti-seizure medications and had frequent school absenteeisms because of seizures. She also had history of febrile status epilepticus at 1 year of age. And in examination, there were no focal neurological deficits. So whenever in seizure symbiology, we have three A's, that is aura, automatisms, and behavioral arrest, that seizure originates from a temporal lobe. This is a clinical clue. Whenever we have aura, arrest, and automatism, that is a temporal lobe semiology. And left upper limb dystonia, that means it is originating from the right side of the brain. So right temporal is the localization. 3 adequately treated ASMs have been tried. She has comorbidities and she had febrile status epilepticus. We all know that febrile status is a predisposing factor for mesial temporal sclerosis, which this MRI shows right mesial temporal sclerosis. So we proceeded with EEG. Here again, EEG shows right temporal epileptiform discharges. We can see other regions are relatively spared. So here also we have a clinical, electrophysiological, and radiological concordance with drug resistance, which is defined. So this is a candidate for drug-resistant epilepsy, and we went for right amygdalohypocampectomy. Currently, this child is seizure-free and has completed MSc Physics. Third case, 8-year-old female on background of prematurity and low birth weight, had non-specific febrile illness at 1 year of age, and then had frequent right focal motor seizures with impaired awareness. Despite multiple AEDs, the seizures continued and she remained drug refractory. At 7 years, she had continuous seizures involving the right side of the body with preserved awareness, which was right epilepsia partialis continua. This is the MRI, which is showing progressive atrophy of the left cerebral hemisphere. We can see prominent sulci, prominent dilated lateral ventricles, and atrophy of head of caudate. So this constellation of findings, that is progressive hemispheric atrophy with chordated atrophy with uh, refractory focal seizures, is classical for Rasmussen's encephalitis. On EEG also we can see that the discharges were from the left side. So we have right-sided seizures, left-sided discharges, and left-sided lesion. So again, there is a clinico-electrophysiological radiological concordance, and with uh, progressive drug-resistant epilepsy. Even she failed steroid courses, which we usually give in Rasmussen's encephalitis, and we proceeded for a left perinsular hemispherotomy, where we disconnect the right and the left hemisphere. It's not hemispherectomy. We don't remove it. We just disconnect the left and the right hemisphere. Currently, she is seizure-free, has subtle right hemiparesis, but is married and independent with 2 kids. So these 3 examples are 3 classical surgeries which we do for drug-resistant epilepsy in children with structural or lesional epilepsies. This was our study from CMC, in which we studied all our Rasmussen's encephalitis patients from 2005 to 2017. There were 38, and 23 of the 38 underwent epilepsy surgery. And of that, more than half had Engel class 1, that is seizure freedom, at last available follow-up. So epilepsy surgery should be done in cases of drug-resistant structural epilepsies because they improve the quality of life and makes a huge change in their further outcome. However, if we only have clinico-radiological concordance with EEG non-lateralization, what next? Should we go for nuclear medicine scans or not? This question was again answered by this study, which was published in 2019 by our teachers. And here also, we had 45 patients, of whom 44 patients were available for follow-up. Majority of them were having hemispheric epilepsy, like Rasmussen's, post-encephalitis sequelae, hemiconventional hemiplegia epilepsy syndrome. And in them also, they had a clinical radiological concordance, but EEG was non-lateralizing. That means if the lesion was on left side, the EEG was also showing discharges on the right side. But as I told, even if we have 2 out of 3 investigations showing concordance, we should go ahead with surgery. And we went ahead with surgery and we found that these patients, even though they had EEG non-lateralization, showed Engel's grade 1 outcome, that is seizure freedom, in 41 out of 44 patients. That is almost 95% of them showed seizure freedom. So even if we have a clinico-radiological concordance and drug resistance and a lesion or a hemisphere amenable to epilepsy, epilepsy surgery should be considered. And all these cases are managed with non-invasive protocol. We do not require any stereo EEGs or any brain surgery before going for epilepsy surgery. So this is the basic lesional epilepsy. So this is the cohort which I did as my thesis in CMC from 2004 to 2016. We went to describe the seizure freedom and functional outcomes of all the patients who underwent epilepsy surgery. Of 91 patients which we screened, 75 patients were included after screening. The mean age of cohort at last follow-up was 18.91 years, and median age of onset of seizures and epilepsy was 15 and 30 months respectively. The median age at last follow-up was 19 years, so we had almost 19 years of follow-up, and median duration of follow-up was 7.25 years. Majority of them had focal seizures, but combined focal and generalized epilepsy was also seen because majority of them were operated late because parents came in late. EEG, we can see only 37% had lateralized EEG and 36% had non-lateralized EEG, and EEG was even normal in 20% of patients. Coming to the etiology, the most common cohort in our group was perinatal insult, the one which causes parieto-occipital gliosis, perinatal arterial ischemic stroke, and hemispheric epilepsy, followed by mesial temporal sclerosis and malformations of cortical development. And Rasmussen's encephalitis contributed 15% of the cohort. So perinatal risk factor is still the most common etiology in our setup. So coming to surgery-related data, the mean age at epilepsy surgery in our cohort was 9.3 years. And the mean age between seizure onset and epilepsy surgery went way beyond 6 years. So if a child has onset at 1 year, they would usually get operated at around 7 years of age. And the mean duration of hospital stay was around 27 days. This includes the pre-surgical evaluation, the surgery, and the post-operative care. This was around 27 days. So these were the procedures which we performed. The most common procedures were peri-insular hemispherotomy, followed by anterior temporal lobectomy and amygdalohypocampectomy, followed by lesionectomy. Only 2 patients required repeat surgery. Right hemisphere was the most commonly operated hemisphere, and immediate post-operative complications were almost minuscule. Only 3% of patients had status epilepticus, and 7 patients of 75 had post-op meningitis, which recovered well after adequate course of intravenous antibiotics. None of them had ventriculitis in our cohort. Coming to seizure outcomes, so this is the ILA scale which we see. So scale 1 is complete seizure freedom, and scale 6 is more than 100% increase of baseline seizure days. So anything between scale 1 to scale 3 is adequate seizure freedom. That is, we define that the epilepsy surgery is successful. So let's see what we found in our cohort. So in our cohort, almost 75% patients had either completely seizure free or had up to only 3 seizure days per year. Whereas we saw in the previous cases, they had almost daily seizures. So it decreased up to less than 3 seizure days in a year. We remove the hemisphere, we disconnect the tracks. So obviously there would be deficits, but we wanted to see what is their functional motor outcome. So of 75 patients, 2 patients expired, and on rest 73 patients, almost 87% of patients walked independently, and only 2 patients were unable to walk. Significant behavioral problems affecting social and family life was seen only in less than 1/5 of the cohort, around 20%. 75% of patients had satisfactory spoken language skills. 60% of patients had satisfactory reading skills, and 2/3 of children had meaningful academic and employment outcomes. So this study reiterates that beyond epilepsy, the functional outcomes of children, the parents usually ask, will my child study? Will my child walk? Will my child gain employment? All these things are the questions which families ask us before proceeding for surgery. And these questions we try to answer with these studies that yes, majority of them will walk, they will have a good behavioral outcome, they will get employment, and they will do good in schools. Visual outcome was also good. Even with posterior quadrantomy, which we did in our patients, only 9% had reported new visual symptoms, but that were not affecting their activities of daily living. So now changing gears from structural epilepsy, we'll go to metabolic cases. So this is a neonate 6-day-old child who had multifocal clonic seizures, multiple episodes since day 3 of life, followed by encephalopathy. Perinatal history was uneventful. However, there was a positive family history that the elder sibling, who was a female, she also died at day 6 of life because of refractory seizures and encephalopathy. On examination, the child had hypotonia with sluggish reflexes, and there were no signs of meningeal irritation. Infectious workup, MRI, brain, CSF, all were non-contributory, and the conventional EEG showed a burst suppression pattern. This child was loaded with multiple anti-seizure medications like levetiracetam, phenobarbital, and phenytoin. However, the seizures and encephalopathy were persistent, and there was persistent abnormality on amplitude integrated EEG. So we know that any child neonate who fails two AEDs should be given a pyridoxine trial. So we gave a pyridoxine trial, and after pyridoxine trial, the seizures aborted, and there was improvement in EEG, and the child got discharged in 3 days. At 8 months follow-up, the child was completely seizure-free, had good developmental gains, and the genetic report showed a mutation in ALDH7A1, which codes for pyridoxine-dependent epilepsy. So this was a case of pyridoxine-dependent epilepsy. It was also drug refractory, but here the treatment varies. This is the second case, a 4-month-old child, firstborn, had seizures since 1 month of age, but see the classical seborrheic rash on the periorbital region and the scalp. He also had developmental delay, failed multiple anti-seizure medications, but this classical picture should make us think of biotinidase deficiency. So whatever amount of anti-seizure medications we give will not work. You start the child on biotin supplementation, and the child at 4 years had very good developmental gains. So this any infant with sparse head, seborrheic dermatitis, failed multiple anti-seizure medications, suspect biotinidase deficiency, levels available or not, give a biotin trial of 5 to 10 milligram per day, and just with that, you will attain sustained seizure freedom and good developmental outcomes. So this is an sort of eye-opening case, and it is very important to catch these findings in a neonate or infant presenting with drug-resistant epilepsy. So this is just a slide I took from Dr. Ingrid Teen's review article on vitamin and cofactor responsive epileptic encephalopathies. So any child which is less than 18 months of age who has frequent or intractable seizures, we have to try these 3 vitamins. That is pyridoxine. We have to give 100 milligram IV bolus with EEG and document improvement in EEG, and then give 30 milligram per kg per day in 3 divided doses for 24 hours. If there is no response, then give folinic acid 5 milligram per kg OD for 3 days. If no response, give pyridoxal phosphate 10 milligram per kg every 8th hourly. So this sequential trial of 3 things, pyridoxine, folinic acid, and pyridoxal phosphate, is important in patients who are less than 18 months and who has unexplained frequent intractable seizures. Any child less than 18 months should get this trial. If that child has seborrheic rash and alopecia, also add on biotin, or give only biotin in that child. That child does not require pyridoxine, pyridoxal phosphate, or folinic acid. So this is a busy slide, but coming to the age of genomics, these are all the genes which we can see when we work up a patient for drug-resistant non-structural epilepsy. And each of these genes have a potential therapeutic measure, which is precise for that genetic defect. So I usually don't remember this slide, but I usually have a screenshot of this to know that if a child falls in one of these categories, which drugs I need to try. So it has 3 categories. Either you supplement or restrict the substrate. So example, if you have a SLC2A1 gene defect, there is a glucose transporter defect. So the brain will not be able to capture glucose from blood. So in that, provide an alternative substrate like ketogenic diet. That will be a treatment of choice. If it is a signaling pathway defect, then we have to give in tuberous sclerosis 1 and 2, we can give rapamycin derivatives like everolimus. Similarly, for various channels, we can give the drugs as described. So coming to non-pharmaceutical therapies, so we have discussed structural epilepsies, metabolic epilepsies, and precision therapies. Now coming to non-pharmaceutical therapies, ketogenic diet. So it started from Hippocrates, who told that starvation is associated with cessation of seizures. And now in 2018, we have clinical guidelines for enteral as well as parental ketogenic diet. And let's see what is the evidence for ketogenic diet as epilepsy treatment. So there are 4 types of ketogenic diet. The classical modified Atkins, low glycemic index, and medium chain triglyceride. So as we go from classical to medium chain triglyceride, the fat content decreases, the protein and the carbohydrate content improves. So basically, when we go from classic to medium chain triglyceride, the compliance increases. Classic is too rigid. it has to have 4 is to 1 fat is to protein ratio. But children usually that food is very unpalatable. Children and parents won't accept that. So as and when the research went on, they decreased the fat content, increased the protein content, and made the carbohydrate minuscule. So that generates ketone bodies, and we'll see how ketone bodies affect epilepsy. So this is a BC slide for all the pathways which we read in biochemistry. All that pathways are affected by ketogenesis. All the anti-inflammatory pathway which we read in Robbins are also affected, and all the microbiota which we read in microbiology are also affected. So all in all, we have activation of potassium channels, which leads to hyperpolarization and stabilization of neuronal membranes. We have decreased reactive oxygen species. We have increased inhibitory neurotransmitters like GABA and reduced excitatory neurotransmitters like glutamate. So ketogenic diet therapy, all in all, is a anti-epileptogenic therapy. And this can be tried in non-structural drug-resistant epilepsy cases. So this was the first randomized controlled trial on ketogenic diet in which 145 children were randomized to dietary treatment or usual care. And the authors noted that within 3 months' time, 38% of diet group had greater than 50% reduction compared to only 6% in the usual care group. So this study gave a class 1 evidence of ketogenic diet in treatment of drug-resistant epilepsy. And this was a recent clinical trial which was done by AIMS New Delhi, where they compared all the three ketogenic diets and showed that in this non-inferiority trial, in 158 children, the median seizure reductions were 66, 45, and 54% on classic KD, modified Atkins, and low glycemic index trial after 24 weeks of initiation of therapy. And all the three diets had similar number of children with seizure reduction. But they noted that the adverse reactions were minuscule with low glycemic index diet. So they concluded that LGIT is considered the least restrictive diet of the three, and which makes long-term adherence more likely. So if you want to start a child of drug-resistant epilepsy on a ketogenic diet, we should start with LGIT diet that will have seizure freedom also and more adherence to treatment also. So these are the various indications of ketogenic diet. We can see all the drug-resistant epilepsy syndromes like Dravet syndrome, Loose syndrome, glucose transporter 1 deficiency syndrome, infantile spasms, Ota-Ara syndrome. All these respond to ketogenic diet. However, we should remember that ketogenic diet is a fat. So if the enzymes which metabolize fatty acids are deficient, then we cannot use ketogenic diet. So before initiation of ketogenic diet, we need to do tandem mass spectrometry and gas chromatography mass spectrometry and sometimes genetic investigations just to rule out fatty acid oxidation defects. So we should know these indications and contraindications and use the diet judiciously. Other non-pharmaceutical therapies for drug-resistant epilepsy are, apart from surgery and diet, which we already discussed, we have responsive neurostimulation and deep brain stimulation and MRI laser ablation, which is usually used for hypothalamic hematomas. And the another novel therapy is vagus nerve stimulation, wherein stimulator is placed in the chest, and through the wire, it stimulates the left vagus nerve. And this left vagus nerve stimulation is usually used in patients who could not be offered surgery as an option. So if they are drug-resistant epilepsies, if they have bilateral lesions, if there are malformations which are bilateral, if it is a monogenic developmental epileptic encephalopathy, they won't respond to surgery. They don't have any precision therapy. They have failed ketogenic diet. In that patients, we can do a vagal nerve stimulation, and it's an efficacious neurophysiological treatment for these patients. And again, it works by altering the neurotransmitter expression. That means it will the shock which is given to vagus nerve will improve the neurotransmitters, will decrease epilepsy. It will improve the cerebral blood flow, and it will also desynchronize the ictal EEG patterns. That means the EEG will become normalized, and this leads to anti-convulsive effect of vagal nerve stimulation. Should remember the left vagal nerve is used for stimulation. And beyond enhanced seizure control, there was also significant improvement in seizure frequency, quality of life, and improvement in mood and behavior in patients who underwent vagal nerve stimulation after failing multiple drugs and ketogenic diet. There is another
Hello. Hello, Sridhar. Hello. Sridhar, we can't hear you. Sridhar, can you hear me? Sridhar, hello. Can others listen to Sridhar? Please somebody respond.
No, no, he is
No.
mute.
He is not muted actually, but let me call him up. He is not taking phone also. We don't. Sridhar, we can't hear you. I hope you can hear me. Sridhar, we couldn't hear you for the last few minutes. So we can't hear you. We lost your audio for last few minutes.
Let me see. He's not getting your message also.
So I tried to call him up also.
It is
Something wrong with his audio.
his phone also not working.
Yeah, maybe his phone is not there with him.
Mhm.
Sridhar, we can't hear you.
Now, sir, can you hear me?
Yes. So
Yeah.
what has happened is that for last few minutes,
Okay.
now nervous stimulation, some slide was there.
Okay.
Last 4 or 5 minutes, we couldn't hear you. So if
Okay.
you can go back to your presentation, we have time.
Sure,
Good
sir.
time with us to continue with your talk. So just
Sure, sir.
present your present. I will tell you when it stopped. So go back on this. I think this was the slide when it go back further. Yeah. Then okay. After this, I think we lost your audio.
Okay, sir. So basically, now I'm audible, sir.
Yes, audible.
So, sir, this last few slides, I'm discussing the non-pharmaceutical treatments for drug-resistant epilepsy. So, these treatments are done for patients who have a genetic etiology which is not amenable to precision
Sorry,
therapy.
we have heard about this ketogenic. I think we heard fully. So
Yes,
what
sir.
is the next slide? Let me see.
Sir, on vagal nerve stimulation, sir.
Okay, okay. So 1 or 2 slides of vagal nerve stimulation we could hear.
Yes, sir. So
Okay.
it is for those who are not the candidates for surgery and a genetic etiology which is not amenable to precision therapy. So in vagal nerve stimulation, we stimulate the left vagus nerve, and based on that, it alters the neurotransmission expression to such a level that GABA and serotonin are increased. They are the anti-epileptic neurotransmitters. It also increases the cerebral blood flow and changes the EEG patterns, which is desynchronizing. So in EEG, usually we have synchronization of rhythms. When we desynchronize, that has an anti-conversion effect, and this is how vagus nerve stimulation works. And apart from sustained seizure freedom, it also improves quality of life and also improves mood and behavior. So the benefits go beyond seizure freedom also for vagus nerve stimulation therapy, and it is the only therapy in neurostimulation which is approved in children with drug-resistant epilepsy. The other therapies like responsive neurostimulation uh, and deep brain stimulation are only approved for adults with epilepsy. So in responsive neurostimulation, the RNS system, which is known as NeuroPace, we have a neurostimulator which is embedded in the brain. Then we have a cortical lead, in which the machine is attached to the cortex, which is showing epileptogenic discharges. And there is a depth electrode, which is there. And after that, what happens is this neurostimulator, it records from both the cortex as well as the depth electrode. So it will recognize that there is a epileptogenic focus in the brain. As soon as it recognizes the epileptogenic focus, it gives a stimulation which desynchronizes the EEG pattern. And then it resolves the EEG signal. So basically, before the seizure starts and propagates through circuits in the brain, the stimulator will recognize those abnormal signals and deliver a counter shock, and the seizure propagation will stop. So in this, it has 4 Rs. It recognizes the EEG patterns, it responds, then it resolves the epileptogenic foci, and it also records what has happened over the time in the epileptogenic cortex of the brain. So this is what is known as responsive neurostimulation. It responds to the electrocorticography, which we do with the help of the cortical and the depth electrodes. So it is also a response rates as high as 70% in children and adults with drug-resistant epilepsy. And apart from seizure freedom, it also improves physical health, mental health, cognitive function in patients with drug-resistant epilepsy. And in this study, they showed that almost 75% median seizure freedom reduction was there at 9 years after implantation of RNS. And this is another recent advance, which is deep brain stimulation of the anterior nucleus of thalamus. So this deep brain stimulation of anterior thalamic nuclei also has similar effects, and this also promotes disruption of the epileptogenic networks. And this is also used in patients who are not amenable to epilepsy surgery and who are resistant to diet therapies as well as vagus nerve stimulation. So these are the various compilation of all the tables of neurostimulation measures, of which only vagal nerve stimulation has been used for children, which are more than 4 years. The rest are only approved for adolescents and adults who are more than 18 years, who are refractory to more than 2 AEDs, and have drug-resistant epilepsy with various comorbidities. And in all these trials, seizure freedom ranged from around 28% and also went up to 70% in some of the results. And these are the various studies which have proved their efficacy over time. And coming to take-home messages, so most important step in management of drug-resistant epilepsy is defining the etiology. We have to see whether there is a structural etiology amenable to surgery or not. If structural etiology is there, if it's drug-resistant, and if there is a good clinico-electrico-physiologic and radiologic concordance, we should proceed with epilepsy surgery based on the lesion. If it's a posterior lesion, posterior quadrantectomy. If it's a temporal lobe lesion, temporal lobectomy and amygdalohippocampeectomy. If it's a hemispheric lesion, peninsular hemispherotomy. If it's not a drug-resistant epilepsy, however, it's a neurometabolic or genetic etiologies, we should have knowledge on precision therapeutics, which will enhance the management of cases with drug-resistant epilepsy. And for non-lesional and monogenic developmental epileptic encephalopathies, which are not amenable to surgical resection, non-pharmaceutical therapies like ketogenic diet, neurostimulation measures like vagal nerve stimulation, responsive neurostimulation, DBS of anti-thalamic nuclei, and pediatric surgeries like corpus callosotomy needs early consideration. And we should remember that each and every case of drug-resistant epilepsy can be managed either with drugs, with surgery, with precision therapeutics, or with non-pharmaceutical strategies as described. I would like to thank my teachers, mentors, and in CMC Vellore who have trained me for pediatric neurology and imparted me an important knowledge on epilepsy and its management. Thank you.
Thank you, Dr. Sridhar. That was very informative and it added a lot of to our, knowledge base regarding management of refractory or drug-resistant epilepsy. Few questions like, all this decision making will require a lot of teamwork. So
Yes,
is
sir.
it possible in a city like Vadodara to have a team which can actually handle such case?
Yes, sir. We have doctors available. So a team requires a neurologist or epileptologist. It requires a neurosurgeon. It requires a clinical psychologist. And all these three things are available in Vadodara. The only thing we require is we need to sit together for a child and do the work. So whatever patches are there, if we collaborate, collaboration is the key. That's what I feel, sir. So I can work up a patient. I can take a good history, localize the patient. I can read my own MRIs. I'm also a certified neuroradiologist now. So once I have a clinico-electrophysiological radiological concordance, that level can be taken care by me. But parents also require objective measures that, okay, will my child improve or not? So we do pre-surgical neuropsychological evaluation that a clinical psychologist or a neuropsychologist that also we have in Vadodara, they can easily do that. And we also have pediatric neurosurgeons who can help us with the epilepsy surgeries. They are trained in all these three types of surgeries. And post-operative care and all those things can also be managed. So if we collaborate, that will be the key thing to do it. So we have the potential. We just have to tap that. That's what I feel, sir.
Very true. And what about ketogenic diet and all? Do we have a nutritionist in Baroda who can actually kind of 3 or 4 types of ketogenic diet that you mentioned?
Sir, I have been trained how to administer a ketogenic diet. I can so basically there are protocols available, sir. There are standard guidelines available. The one which I quoted by Dr. Eric Kossoff. So they teach how it has to be given. The only thing which we have to keep in mind is, okay, the food preferences of the child. Like some may not eat eggs. So if I want to give a high fat diet, I might have to include non-vegetarian diet, but the parents may not be receptive to it. So how to increase the fat content in a vegetarian diet? So we'll have to add more of olive oil. We have to use more of cream, butter, and all those things. So the palatability is the issue, but the low glycemic index diet, which has come up recently and has been studied in a randomized control trial, is also a good diet. And there are fixed protocols available, sir, which we can do with the help of nutritionists. And I can both collaborate together and give a child a good schedule for ketogenic diet also. That also I have been trained in, sir.
Any other questions or comments?
Vagal nerve stimulation would have some side effects on cardiovascular system.
No, sir. Actually, for the want of time, I did not tell that. The thing is, how does vagus nerve stimulation occur? So the vagus nerve is stimulated in the neck on the left side. So how does it know that whether it has to give stimulation or not? So basically, whenever we have seizures, the heart rate increases. And thus,
Okay.
when the heart rate increases, that is what is picked up by that stimulator which is kept in the chest. And then it delivers a shock to vagus nerve, and the vagus nerve alters the neurotransmitters in the brain. So there are some patients may have bradycardia, some may have asystole also, but it's not that much that it will prevent that will deteriorate the quality of life. The benefits of vagal nerve stimulation are far beyond the side effects. So side effects can be there. They can have intermittent asystole, may have syncope, but with time they usually adjust to it. That's why that therapy has also been tried in children. Whereas RNS and all, they are very costly therapies. Vagal nerve stimulation is around 4 lakh to 6 lakh basic things cover. It is also surgical implantation of the electrodes around vagus nerve. But RNS and all goes up to 30 lakhs and all. And they are not even approved in children. So vagal nerve stimulation can be tried. I have seen only few cases. So I will require a good surgical team for that. Matlab, even only in those cases which are not amenable to surgeries and which not have good precision therapeutics and which are refractory even to ketogenic diet, we would go for vagal nerve stimulation. That would be approximately 1% of patients, I think, of drug
In
resistant
fact, in
epilepsy.
comparison to major lobectomies of brain, I thought vagus nerve stimulation is much simpler if it works better.
No, sir, but in the surgeries which we did, we have seizure freedom going up to 80-85%, even up to 95% in our cohort. Whereas vagal nerve stimulation, the seizure freedom will be only up to 70% of the cohort, and that too who have not been amenable. So if there is a lesion and if it is amenable and if it's drug resistant, epilepsy surgery should be done. And we showed by our study that they have good functional outcomes also. So they do walk, they do go to school, they have a good vision outcome, they are employed, and they do go on to develop good academics also. So majority of our patients have completed MSc Physics, computer science. They are very well employed. So the fear of lobectomies or hemispherotomies should go away. If it's a lesion and if it's amenable, we should go ahead with surgery. That will give them a good seizure freedom as well as functional outcomes.
So, Sridhar, when you talk about better functional outcomes, does it mean that they improve upon what they were before the treatment, surgical
Yes,
treatment?
sir. Yes, sir. So majority of patients who are there, so the ones with temporal lobe epilepsies, the mesial temporal sclerosis, they have a lot of behavioral and cognitive side effects because of the limbic circuits which are involved in the
Mm.
temporal lobe. As soon as we do a temporal lobectomy, first thing happens is they are on 3 or 4 drugs. Within a span of 6 months to 1 year, we can taper down all their drugs. So drug-related cognitive and behavioral side effects will go. Then
Okay.
we have seen that in long term, after 5 years, they're basically because of frequent seizures, they're not going to school, they're not interacting with kids. So they start going to school, the social interaction improves, their communication improves, and their cognition also picks up. So basically, the thing is, the cognitive circuits are under load of
Mm.
epileptogenic foci. Once we remove the epileptogenic foci, the cognitive circuits rebound and they do give a good cognitive outcomes. So they improve very much. So the children which I presented was not able to go to school, was failing in multiple subjects. But after surgery, that patient completed MSc Physics. So it improves, sir.
It happens irrespective of the age when the surgery is done, or beyond certain age, they don't improve.
It should, the dictum is the earlier the better, sir. But we showed that in our cohort, the mean duration between the diagnosis and the epilepsy surgery was almost 7 years. But in that also we had good outcomes. So it should not discourage. Even our adult epilepsy team, we have
Mm.
adult neurology also. They also do epilepsy surgery in temporal lobes.
Mhm.
The hemispherotomy ones, the hemispheric ones, they once what happens, it is in one hemisphere. As the age progresses, the network shifts to another hemisphere.
Right.
Then if you do a late surgery, the seizure freedom and the functional outcomes may not be adequate. But for posterior cortex epilepsies and for temporal lobectomies, you should do because that gives an more than average chance of improving their cognitive and behavioral concerns. So even adults with temporal lobe epilepsies, temporal tumors like focal DNETs, focal cortical dysplasia, they do undergo epilepsy surgery and they have had epilepsy since their childhood.
Hmm.
So our adult team also ropes in. So in our epilepsy surgery meetings, which we have every Saturday, today it goes on from 10 to 11. There is adult neurology will have 2-3 cases, pediatric neurology will have 2-3 cases, and all of us will discuss. Neurosurgeons will pitch in, and then based on this clinico-radiological, electrico-physiological hypothesis, we propose a surgery, and the surgeons do that surgery. And the post-operative care is again taken care of by us or adult neurology. Like
So out of drug-resistant epilepsy, say 100 cases, how many will end up with surgery? How many with your therapeutic, specific therapeutics and other stimulation, etc. So any breakup of that data?
yes, sir. So of all the epilepsies, means adult and pediatric combined, 1/3 of the epilepsies are drug-resistant epilepsies.
Hmm.
And in that 1/3, 2/3 of them are structural drug-resistant epilepsies, and 1/3 are non-structural. The structural ones who are unilateral should undergo epilepsy surgery, and the non-structural ones should undergo non-pharmaceutical strategies like ketogenic diet and responsive neurostimulation, like vagal nerve stimulation.
Okay. So almost 60-70% would require surgery.
Benefit, yeah, of that cohort. And there is a large lacuna. Even there are now some 4-5 centers in India doing epilepsy surgery. Still, the patient waiting list is very much.
Hmm.
And patients also come in late. The thing is, they are not referred. People keep on trying drugs. We have had patients who have been tried with, they are on 8 or 9 drugs. So beyond 3 drugs, 4 drugs, nothing would change. You keep on adding, nothing would change. If there is a lesion, you have to remove the lesion.
But some percentage of your patients in your study I saw was that scale 6, where the outcome is
Yeah, sir.
was
So
that they
that
deteriorate, I mean, further.
deteriorated, yes, sir. So I'll tell you that
What
patient
do you
was
do
a
with them now? Even if, I mean, surgery, if the surgery is
so
specific,
that patients we have started on ketogenic diet, sir, and one of the patients we have offered a vagal nerve stimulation.
Okay.
That patient, what happened basically, I'll tell you that patient had febrile status epilepticus. After that, he had mesial temporal sclerosis and he underwent a temporal lobectomy. But he also had a SCN1A mutation. So because of SCN1A mutation, he was a developmental epileptic encephalopathy. So although the lesion was focused on the temporal lobe, all his cortex cells were having that mutation. So even when we removed that lesion, the other mutation was still expressing the epileptogenicity. So he failed it. So that's why for the ones when we undergo epilepsy surgery, nowadays we have also started doing genetics in patients whom we suspect that, okay, it will be a genetic epilepsy, also having a structural component. So if it's a pure structural component and other things are okay, then we do go for surgery. But if we feel that it has a genetic epilepsy and it may have a expression over the entire wide range of cortex, we do genetics. And if it's a genetic etiology, we don't offer them epilepsy surgery in most cases. Like something like tuberous sclerosis, if they have one tuber, we can offer surgery. But if it's like something like SCN1A, which is global, we don't offer them surgery.
Got it. So thank you very much, Dr. Sridhar. It was really, really very, very informative. And we do look forward to some more talks in future. So thank you for being with us. We meet next Saturday morning again. Thank you all. We end the session here. Thank you.
Thank you.